We are really excited to have this because this is a very important topic, not only with general preventive immunizations, but also with COVID vaccine immunization in the Commonwealth of Kentucky. We'll find it extremely interesting for us to hear and to be able to ask questions concerning the challenges and issues affecting immunization rates in the Commonwealth of Kentucky. So without further ado, we will ask our first presenter, Dr. Christina Bryant, to begin her presentation.
Thanks so much, everybody. This is Chris Bryant, and I really appreciate the opportunity to be here today. I work at Norton Children's Hospital and the University of Louisville, and I want to talk to you a little bit today about early childhood vaccines, success stories, and opportunities. My disclosures are on this slide, and I want to just remind you that immunizations have been called one of the greatest public health achievements of the 20th century, with more than a 95% decrease in vaccine preventable diseases in just the last 50 years. So the CDC did some modeling on the impact of vaccines on children born between 1994 and 2013. Why 1994? Well, that was the first year of vaccines for children. I hope you caught the last presentation. Corey Meadows actually ran these numbers. So I won't do it again, but I want you to just take in the tremendous impact of the immunization program. But the numbers really only tell part of the story. So to tell you the rest of the story, we're going to need to talk about parents and children. In 2021, no parent goes to bed worried that their child is going to catch and die from diphtheria. But that wasn't always the case. In the 1920s, when my grandmother was a child, there were between 100,000 and 200,000 cases of diphtheria every year, and as many as 15,000 deaths. A safe and effective diphtheria vaccine became available in the 1940s, but not everybody was immunized. And I want to share with you a story that was shared by Carolyn Hardman with the Immunization Action Coalition. Carolyn writes, in 1961, I tended my young cousin while her mother went to work. She was ill with a fever and complained of a sore throat. The next morning, she was unable to breathe and began turning blue. An ambulance was called and she was transported to St. Mark's Hospital in North Salt Lake. There, the doctors did everything they could for her. They performed a tracheotomy, but she passed away that afternoon from diphtheria. You see, there was a diphtheria vaccine available, but Lois's parents just hadn't gotten around to getting her immunized. Fortunately, diphtheria has become extraordinarily rare in the U.S., thanks in part to the Vaccines for Children program. Between 2004 and 2017, only 2 cases of diphtheria were reported in the United States. If we go back in time to 1944, this is at the start of the Vaccines for Children program. This was the recommended childhood immunization schedule. There were 9 different diseases that were represented on this immunization schedule. Let's fast forward to 2021. It looks a lot different. A child who receives all recommended childhood immunizations by age 2 will be protected against 14 different diseases. Unfortunately, immunization rates and the opportunity to be protected from vaccine preventable diseases is not uniform. Immunization rates are lower in the uninsured or in populations who have Medicaid. They're lower in those living below the poverty line, and they're lower in individuals who are Black, American Indian, or Alaskan Native. Now, when we talk about vaccines being a great public health achievement, we're really not talking about the dose of vaccine in the syringe. The achievement comes from getting the vaccine dose into a child. And Kentucky is falling behind, as you see on this slide. On the left, you'll see the percentage of children who by age 35 months have received all the recommended doses of diphtheria, tetanus, acellular pertussis, measles, mumps, rubella, poliovirus, Hib, hepatitis B, varicella, and pneumococcal conjugate vaccine. So by 35 months, only 71.9% of kids in Kentucky are up to date. We ranked 43rd in 2020 in terms of immunizing our children. And unfortunately, we're getting worse, as you see when you compare data from 2019 on the right to data from 2020 on the left. Now, I suspect everyone at this conference saw the headlines last summer: immunization rates drop precipitously in children. We are putting our children at risk for vaccine preventable diseases. I'm sharing on this slide data from the Kentucky Immunization Registry, and many thanks to Judy Theriault for pulling these data. But if you just look at the blue line, you'll see vaccine doses administered to children in Kentucky 0 to 18 years of age in 2019. Then look what happened in 2020. That's the red line. In the spring of 2020, with the onset of the pandemic, children stayed home. They weren't going to their pediatricians or family physicians for preventive health care, including immunizations. Even though the AAP said, let's prioritize young children, let's get them in, they stayed home and vaccine doses fell. And what you see on this slide, when we compare just those under 2, 2019 to 2020, there's a gap. And we are failing to close that gap despite appeals. On the right-hand side of the slide, you see the percent change from 20 to 21, and we are not making up the gap that happened early in the pandemic, which means that we are leaving our children at risk for vaccine preventable diseases. I want to switch gears really quickly and talk about COVID-19. Early in the pandemic, we thought maybe children didn't get infected with COVID-19. Maybe they didn't transmit it to others. And of course, we know this is untrue. Since the start of the pandemic, more than 5.3 million children have been infected with COVID. And there have been nearly 500 deaths. At the end of August, children represented nearly a quarter of all new cases of COVID-19. I will tell you that I practice pediatric infectious diseases at Norton Children's Hospital, and we have seen a sharp increase in the number of children diagnosed with COVID-19, as well as the number of children hospitalized. There were many days in June when we had no children in the hospital with COVID-19. In August, and early September, we have had as many as 23 children hospitalized on a daily basis when we look at our daily census. These are total numbers. In August, we had 31 children hospitalized with COVID-19. Some of them stayed for many weeks. Please don't be reassured by September. This graph was data through September the 4th. But the good news is COVID-19 is now a vaccine preventable disease, at least in children 12 and above. That may soon be true for children as young as 5. I want to close with the message that vaccine works. Norton Healthcare has delivered more than 10,000 vaccines to children 12 and above. And I want to share with you 2 pieces of information. Number 1, if we look at the 10,000 kids that we have immunized, none of them have been hospitalized. If you look at the counties where those vaccines have been delivered. That's the graph on the left. There is an inverse correlation with the number of cases of COVID-19 diagnosed in children. So in the counties in the zip codes where we have delivered the fewest vaccines, we see the most cases of COVID-19. So how are we doing in Kentucky? Well, on this slide, you see the percentages of children 12 through 17 who've received at least one dose of the COVID-19 vaccine. Nationally, 59% of 16 to 17-year-olds have received at least one dose of vaccine, and approximately half of 12 to 15-year-olds. In Kentucky, again, we're falling behind. As of September the 8th, 44% of our children have received at least one dose of vaccine. And on this slide, you can tell where we rank in terms of other states. We have some catching up to do to protect our children from COVID-19. I'll just close with this slide. You've heard this message before. This is from the CDC's Vaccinate with Confidence program to increase immunization rates, whether we're talking about routine childhood immunizations or COVID-19 vaccine. We need to engage trusted community partners. I'll stop there and be happy to answer questions later on.
Please feel free to put your questions into the chat, and we will continue with our next presenter. Thank you, Dr. Christina Bryant. It was a wonderful presentation, very informative, although a little alarming to me, but thank you very much. Our next presenter is going to be Dr. Julia Richardson. Early childhood vaccines, best practices and policies.
Hello, let me get my share screen up. Just want to spend a few minutes talking about early childhood vaccines, best practices and policies. And it's so related to the COVID vaccine issues. So many of the same issues apply to getting children their early childhood vaccines as getting everyone their COVID vaccine. So I'm going to just touch on a few things, some practice-based strategies, policies and practices that work, gaps and opportunities for improvements, and then wrap up with an idealized situation. So a little bit about the work I do. I'm at Family Health Center Iroquois, mostly serving families in South and Southwest Louisville. About 75% of the families I serve are non-English speaking, and about 99% have Medicaid or are uninsured. So first, some practice-based strategies. I wanted to start with a little case. So this is little Amy, a hypothetical patient. She's 7 months old and she's brought in by her father for a fever. Her regular doctor is out of the office, so I see her for a visit. She is acutely ill with moderate illness, and we give her antibiotics, then fever and pain reducer for her ear infection. So what else? So the background is she was worked in as a sick visit during a very busy day. The nurse alerted me that the infant was behind on vaccines. And then I ordered and the nurse administered 4 injections and 1 oral immunization. It took about 10 to 20 minutes of staff time. The nurse gave them their vaccine record for WIC and daycare, and then we followed that, scheduled the follow-up appointments for her next checkup and her flu number 2. So what are some strategies in practice that work? So the Immunization Action Coalition, so immunize.org, has a nice set of criteria that are excellent strategies. So some of the things that work during that office visit is, first, we keep our staff up to date with current recommendations. We're very pro-vaccine culture in our office. The nurses know the schedule and monitor the same way the providers do. We maintain up-to-date patient records, so we have carefully customized our EHR for easy access, documentation. The third thing is maintaining and protecting the vaccine supply. So this is a huge burden to providers who are providing vaccination. And so we have to monitor safe storage, data reporting, and monitor supply. I mean, we have to stay with a full refrigerator of vaccine, which takes a lot of staff time. Avoiding missed opportunities. So this was a sick visit. They weren't my regular patient, but still, we got the vaccinations completed. And maintaining admin best practices for vaccines. So making sure we're screening for medical contraindications and giving vaccine information as appropriate. So what else went right during that brief visit to get those, what would seem to be a simple thing, right? Getting vaccines to a child when they're in the doctor's office. Well, we were sufficiently staffed and we had nurses that are comfortable giving childhood vaccines. And the child had Medicaid, and we were participants in the Vaccines for Children program. So a lot of things, even in a medical office, have to go right to get vaccines into children. So what didn't go right? So there's some strategies that we missed the mark on that visit. So there were 4. So first, help your patients anticipate their need for vaccines. So that patient and family missed their 6-month visit. So I wonder why that was. Improve access. So why didn't they come in on time? Was it transportation? Were there not appointments? And communicate with patients and parents. Did we not communicate well enough that they knew that they had to come in for that 6-month visit? And then evaluate and improve your practice performance. So looking at a population-based approach. So what practice-wide innovations could we have afforded to prevent this? So tracking, recall, those are all best practices, but they're expensive and they're not paid service by insurance companies. So what are some policies and practices that do work? So first, we have to eliminate financial barriers, and we're still not there yet. We still have families that feel like they cannot afford vaccines, even though we have Vaccines for Children programs. So the Affordable Care Act did require vaccine coverage for the commercial insurances. Vaccines for Children is a program implemented back in the 90s, and it's for vaccine access for children under 19 who have Medicaid, who are uninsured, or who are American Indian or Alaskan Native. But it's an opt-in program. So it's not, if you take Medicaid, you get these free vaccines. It's a pretty intensive federally funded, state administered program. But again, that's an opt-in program, and it's not universally available because there is a significant administrative requirements. So that's one, eliminate financial barriers. The second is improve access to vaccines. So we have to look at, as a society, how do we give better opportunities for families, locations, times, things like that. Addressing vaccine hesitancy. Although a lot of talk in these last several presentations today are really talking about the role of the provider, the medical provider, we can't do this by ourselves. We really need this to be a societal, a public health approach around vaccine awareness and vaccine trust, because we do it all day long in the office, but we need people to come into the office prepared with knowledge and information around the effectiveness and importance of vaccines. And then another potential policy that has worked in other states is Kentucky still has an exemption for vaccine requirements for daycare and school attendance for religious reasons. And there's even just a checkbox on the vaccine certificate that says religious objection. And so I think that's something we need to continue to look at from a policy perspective. So what are some gaps and opportunities for improvement? If you look at, these are all vaccines in Kentucky from in 2019 to 2020. And you can see it's small, but the months are across the bottom. So this is comparing 2019 to 2020 and January through July. And so you can see the percent changes. So I'll put some red marks. So in the 3 to 6 years, 7 to 13 years, there was up to an 80% difference in vaccines administered between 2019 and 2020. And it's 2021, and we don't have the data, but I can assure you we are not where we want to be. So what do we need to do? So what are some opportunities for improvement? So especially in the context of the current data, I think there's some opportunities. So first, as advocates, we need to understand the complexity of the office visit vaccine administration. So I went through that scenario. There's so much going on in the background just to get children who are even trying to access vaccines a vaccine. And we have to really be aware of and look at the administrative burden of VFC. We need to understand why providers stop providing VFC services or why they've never signed up. I think we need to understand that a lot better to be able to expand the reach of VFC. and mitigate those barriers. We need to help communities pay for effective public education or social marketing strategies, so that sort of community-based public health approach. We think it's important for communities to consider community-based access needs. And so this is so different from community and within communities. So, so what about flu vaccine access? The primary care offices cannot handle seeing every single person in the community during the months, of October and November to administer a flu vaccine. It's just the numbers. The numbers don't add up. There's no way to get all of those people in. So we really have to look at access. And I think flu vaccine is a great example, especially for traditionally medically underserved population. And this applies to COVID vaccine as well. There's not the capacity in primary care for everybody to get their vaccine there. We want partners to continue to maximize functionality of the immunization registry. We're close, I think, to having something that's really powerful, and we need to continue to work on that. And then consider that elimination of all but medical exemptions for childcare and school attendance. I think that's something we haven't really talked about in Kentucky, and other states have done very successfully. And of course, we have to carefully consider all the racial justice issues in all of these opportunities. So let's go to what an optimal outcome would have been for Amy. So first of all, when Amy was born, she would have been effectively signed up on Medicaid, and that Medicaid would have been uninterrupted during her childhood. Her parents could have learned about vaccines and the vaccine schedule at the grocery store, so that it's a milieu where there's great awareness around vaccines. She would have been enrolled in HANS, and our HANS provider reinforced the vaccine schedule. That's our early visitation program in Kentucky. Her early child care providers or WIC providers would continuously ask for that updated vaccine record. So again, that just encourages families to be aware. Her family, if they only have reliable transportation on Wednesday afternoons after 3 o'clock, we have an immunization delivery system that can meet those needs. And that's a huge issue around access. In addition, her parents had been vaccinated for Tdap, for flu, for COVID, because those vaccinations were free, available to everybody in the community, and accessible. And then her healthcare provider's office would track and recall for any missed vaccines, and a community health worker could reach out to the family to discuss access barriers, and all of these activities would be paid by her Medicaid insurance. So that's best case scenario for little Amy, just to bring all of the opportunities, gaps all together. I do think we need to think about vaccination and childhood vaccination like a chronic illness. You remember back in the day, we thought, oh, if somebody had an A1C of 13, they just needed to do better. They needed to eat healthier, and it was really within their personal control. And now we know with all of the interventions that this is really, it involves the entire community, the health system, the medical neighborhood, family, friends, everybody, to help somebody with diabetes have good control. It's the exact same thing with childhood immunizations. We really need to approach it like the same way we approach chronic illnesses. So, thank you.
Thank you very much, Dr. Richardson, for that very informative information about Vaccines for Children program and policies to improve children's immunization rates. We will have questions at the end. Please feel free to put your questions in the chat. And thank you all very much. This has been very informative for our audience and for me. Our next presenter is going to be Dr. Castrucci. He'll be communicating effectively with parents, guardians, educators, and other stakeholders about vaccines for children. We'd like to welcome Dr. Castrucci to our panel.
Thank
and I
you.
apologize if I mangled your name. I do apologize.
Oh, that's okay. So hopefully you're hearing me. Give me a thumbs up that you're hearing me. Hear you, good. And making sure that I'm going to put the slides up now, that we see the slides. If you don't see the slides, someone pop in and tell me. So good morning or afternoon, everybody. My name is Brian Castrucci. I'm the president and CEO of the Beaumont Foundation. At Beaumont, we advance policy, build partnerships, and strengthen public health to create communities where everyone can achieve their best possible health. I'm a public health practitioner who happens to get the great privilege of working at a philanthropy. I spent 10 years in governmental public health before joining Beaumont. And so our role in the COVID-19 pandemic has been messaging. And while what I'm going to share with you today is our data from parents of 12 to 17-year-olds, we pretty much know by, I think, if I was a betting person, I would bet before Halloween, we'll have vaccines available to 11 to 5-year-olds. So I think these data can carry to that age group, but just wanted to talk through some ideas that we've had looking at national data that I wanted to share with you today. So I'm going to start with some data. This is just to set where we are in our nation, right? How many of your close friends and family, if any, generally agree with your views and opinions about politics and elections? What this data point demonstrates is just how much of an echo chamber we are living in, where, high rates of both, Democrats and Republicans say, more than half of their friends and family agree with their views. Now, this is important, and we'll get back to this data point a couple times. How many of your close friends and family, if any, have received the COVID vaccine? So we asked, and this is what this data point shows, is the proportion of vaccinated and unvaccinated who say half or more of their family and friends are vaccinated. 78% among the vaccinated say more than half of their friends are vaccinated. Only 22% among the unvaxxed. So those family and friends, when it comes to those family and friends who have relationships with those who are unvaccinated, these are probably the most important people we have, especially if we have parents who have vaccinated their kids, but have social networks that include the unvaccinated. This is the way we're going to break through echo chambers. And we need to mobilize those groups to help us with this, with our shared cause of getting more people vaccinated. I thought this is always a very interesting graph that again, to set where we are nationally, which is a greater threat to your personal health and safety. For the vaccinated, 75%, when given the choice of getting COVID or mandating the vaccine, 75% said they're more afraid of getting COVID, while 66% of the unvaccinated said they're more concerned about getting the shot. And then we asked, which is a greater priority, personal freedom or public safety? And you see the disparity between vaxxed and unvaxxed when it comes to this dichotomy. Now, I share these data just to kind of ground where we are nationally, but I'm going to argue that when it comes to the political divide around COVID vaccination, parenting trumps politics. Okay, and I think we're going to see that in the data I'm about to share from a national poll of parents. When we asked, had their child already been vaccinated, you see these data. I would note that of the vaccinated, these data were collected in early August. 60% of vaccinated parents say that their kids have already been vaccinated. So there's an opportunity there for us to push that number higher, right? And that's one of our opportunities. How likely is it your child to get a COVID-19 vaccination? Now, okay, let's talk about this for a quick second. Don't focus on the gray, right? The dark gray and the light gray are the probably nots and definitely will nots. It's easy for us to focus on that. Media is going to focus on that. Let's focus on the blue, okay? Especially those first two blues. That when you really look, how likely is your child to get a COVID-19 vaccination? Even among unvaccinated parents, 43% said absolutely certain or probably. Among Republicans, we had 36% saying absolutely certain or probably, with 23% more saying possibly but not sure yet. There's our opportunity, right? There all of that in the blue is where we can make real inroads in getting our 12 to 17-year-olds and eventually our 5 to 11-year-olds vaccinated. The spread of Delta is something that is driving an increase in the likelihood of getting kids vaccinated. Again, looking at Democrats, clearly 82%, much more likely, somewhat more likely, but even among Republicans, 49%, much more likely and somewhat more likely. So I want to encourage us to not continue to play into a national narrative of broad sweeping generalizations about any group. We are a much more nuanced society than I think we've ever been. And it's not all of this party believes this or all of that party believes that. This I thought was really important. This was a national question again. How safe do you think other childhood vaccines like measles and mumps are for your kids? Over 90% or more for both GOP or Dem parents. Then we asked, how safe do you think the COVID-19 vaccines are for most children? There was a 6 percentage point drop among Democrats. There was a larger percentage point drop, a 23 percentage point drop among GOP parents. But note, 67% still said it was safe. Okay, I feel at times, and maybe you guys feel the same way, like we're fighting this idea that all these people think this vaccine is unsafe. The data don't support that. Now, it's different in pockets, and it may be different in Kentucky or Ohio or other places, but still, nationally, what we're seeing is that people think these vaccines are safe for kids. Asked, except for students who can't get the vaccine, once there is a vaccine authorized and available for your kid, do you think vaccination should be required? 53% think it should be required. 40% of Republicans, 38% of the unvaccinated, 66% of the vaccinated, 64% of Democrats. So again, even requiring the vaccine is polling, 2 to 3 among Republicans. So it's not a giant gap. It's not 90 to 10. In several states, schools are not allowed to enact mask mandates for students. Given the Delta variant, which would you support? 61% said they supported the school making that mask choice. For vaccinated, it was over 70%. And for unvaccinated and Republicans, it was split. But again, we are not talking about 90% of the unvaccinated saying we don't want mask mandates. But if you listen to the news, you might get that impression. So we have to bring these conversations back locally and really have a much more thoughtful conversation that recognizes that not everybody believes everything we're hearing on TV. When we looked at Delta, again, you see how these data distribute, that Delta variant does make people more likely, parents, more likely to support a mask mandate. So those are the data, right? The data are what the data are. I want to talk about some of the action we can take. And I believe fully that the antidote to misinformation is trust and credibility. You in this audience, local health officials, families, physicians, friends, that's the trust that we have to cultivate. One of the resources I want to share with you all is this communications toolkit called Phrases. It's about public health reaching across sectors. Public health's not going to be able to do this alone anymore. We need to have other partners. Phrases is a toolkit that allows you to reach out to other sectors, business, education, healthcare, gives you a toolkit of information, resources, ways to communicate, metaphors to use that will help you build some of those linkages. When we're thinking about action, we got to always talk about mobilizing our allies. If you go to changingthecovidconversation.org, there is a ton of resources here. This happens to be on the screen, what we're using as a physician toolkit. It was a physician toolkit that we launched with our partners from the Association of State and Territorial Health Officials, just about how physicians could engage with their patients about COVID vaccination. We got to mobilize our faith leaders. We got to mobilize our business leaders. We have to make sure that as the two previous presenters talked, This is a safe vaccine. There's a lot of misinformation out there about this. We have to keep pushing the real information. I think Dr. Bryant said 10,000 kids, no hospitalizations. Those are the messages we have to hit. And then the messaging research, which is always helpful. And this is just around how we get people to help take this vaccine. When it comes to schools and it comes to kids, 3 messages that hit really strongly. Safety of students, teachers, and staff. That's the first priority. Commitment to making sure that they're limiting the spread of COVID-19, that ensures schools can remain open and safe for students. And lastly, a really strong message is about education. Students need to be back in school physically to get the education they deserve. These are messages that are a winner among everybody because parenting trumps politics. Parenting over politics. I don't care how you vote. When you put your kid's safety on the line, that's what you care about as a parent, number one. That's something we should be capitalizing on. When we look at for reasons that children should get vaccinated, parents chose these as convincing reasons to have children vaccinated. It's the best way to protect our children. It can help children stay in school safely and get the education they deserve. I have a 10 and a 12-year-old. I want my kids safe, and I want them to get a good education. I'm not willing really to sacrifice either one. I want both. Parents can protect their children from needing hospitalization or having long-lasting COVID symptoms. Pediatricians recommend that teenagers get the COVID-19 vaccine. In your communities, get those pediatricians out on social media, pushing that kind of micro-influencer model, right? Get folks who are family and friends or conservatives and known conservatives in your community to get out and talk about this vaccine if they believe in it, right? Getting those micro-influencers mobilized will be really super important. Medical science has proven that other vaccines keep dangerous diseases and viruses away from our children. The COVID-19 vaccines are no different. This is the most important thing you can say to anybody around COVID vaccination. I understand you have concerns. What questions can I answer for you? There's been a lot of vitriolic fighting and harassment, and that has to stop. I've heard media talk about herd stupidity among different political parties. That's not helpful. We need to make this a medical conversation and a vaccination conversation, not a conversation that is politicized. We have a role in depoliticizing this conversation. Don't fight, don't debate. Debates have winners or losers. Educate and inform, and then step away, right? Just let people know that you're there should they have questions. Never let a big event go to waste with the FDA approval of COVID vaccines, with any outbreak or spike. Make sure that you're messaging around those big moments. We have this resource for you. This is the Public Health Communications Collaborative. When it comes to COVID, when it comes to vaccination, free resources, free infographics to help you, and free messaging out to help you better communicate with those in your community. And then bottom line here, everybody, we know this. Sometimes you just got to turn to mandates. And Joe Biden did that recently with the Department of Labor rulemaking. If you follow this URL right here, this tiny URL, it is a Twitter thread that documents all of the mandates that are happening around COVID vaccination. So at some point, when you've educated all you can educate, then you have to turn to something else. And I fully, 100% think that everybody has a right to make a decision about vaccination. It is your right. It is your choice. But your choice should not imperil me or my family. And I think that is the critical issue here. And we just have to start saying, in some instances, no, you can't go to that football game if you're not vaccinated. No, you can't go to your child's graduation. So I hope this was helpful. I'm looking forward to a conversation and answering some questions. But for me, that's what I have for today.
Thank you so much, Dr. Castrucci, for that informative information. You addressed many of the key issues that we struggle with each day in our healthcare community. So we do have a couple of questions in the chat, And we have some comments from Dr. Richardson as also. First of all, I'll go to the questions first. One question is, how can we move vaccines for children past politics and into a discussion about their health and the health of their community?
So if I could jump in on that one, I think that I think it's important, to talk about vaccines and the COVID vaccine. So typically vaccines, early childhood vaccines, vaccines through kindergarten, they're not controversial. These are not politicized conversations. And we also struggle to get those vaccination rates up, right? So Dr. Bryant really articulated those numbers were bad before COVID, before the access issue. So there were access issues before COVID. There are access issues now that we're in the midst of the pandemic and access to care. And so I think that there are two conversations. One is, how do we increase access to vaccinations for children? How do we increase access to vaccinations for COVID vaccine? But they have a lot of the same answers. Children are coming to me, they wanted the COVID vaccine. They're 13 years old. They could have gotten it back in May, but they didn't get it. It's not because they didn't want it, it's because it isn't accessible. And by accessible meaning, you shouldn't have to try to get vaccinated, right? It should be so accessible, it's the default. Like, oh, I can just get vaccinated. It's so easy. I can go to a place that's convenient to me at a time that's convenient for me and get vaccinated. We're having the same problems with COVID. And I think that we have to look at the access issue in addition to the refuser issue. Most of the families that I'm seeing want the vaccine and they just haven't been able to get it. I had a mom say, look, she wanted it. She has no car, no transportation. She has three little kids. She's like, how am I supposed to get the COVID shot? Like, I can't go and get it. So we really have to rethink our approaches as neighborhoods and as communities on what's working and what's accessible. So what we're doing isn't quite where we want to be, for sure.
This is really good information, and we want to continue asking the questions. Dr. Bryant, can you hear me now?
I can, thank you.
Thank you very much. I'm the CEO of an FQHC, and one of the things we did in terms of access is to have a mobile van that we can take the vaccines to people, have immunizations off-site in our scope, and have transportation vans. But all programs do not have those kinds of resources available to do that. So can anyone suggest other ways that we can make sure vaccines are accessible and to the broader community in ways that don't involve transportation barriers or access barriers due to geography?
I think one thing that will help is having the vaccine in pediatrician and primary care offices. So CDC surveyed teenagers and parents several months ago and said, where do you feel most comfortable getting your vaccine? And they wanted it in their pediatrician's offices because that's where they're used to getting vaccine. And that's where their trusted health messenger lives, right? It's their pediatrician or primary care doctor. And so I think that over the last several months, we've seen increased availability in pediatricians' offices. That's not going to solve everything because some families still have transportation issues, as Dr. Richardson pointed out. So, one thing that Norton Children's did early on was partner with schools and have events in schools. So that, number one, I think increased access. But there's also a peer component, right? If everybody's getting immunized at the same time, that can promote confidence.
Thank you very much.
Can I add on one thing there?
Yes, certainly, Dr. Castrucci.
When it comes to COVID specifically, we knew this from the start, and we made a bad misstep, I think, as a nation. Mass vaccination sites don't necessarily appeal to people for just one reason. Let's look at the word mass, M-A-S-S, okay? Do this with your family and friends tonight. say, what word comes to mind when I say mass blank? There's some really great words like grave, shooting. It's not a good word. And so we weren't ready for this as a public health community, which is really amazing because we always knew it was coming. I think, we've seen, I always love these kind of media conversations about, I'm very surprised that people of color aren't necessarily getting vaccinated. I've heard this Tuskegee thing. Like, is that new? Did we not know about that for decades before? We didn't put in the work to make us ready to fight this vaccine, and we got to learn that. The problem is we got 26 states that are actively gutting public health right now, and we are already failing the next pandemic before we even know what it is. And so these are the things we have to look at and keep vigilant about.
And that's very important for us to remember because you mentioned the Tuskegee study. Most of the patients that we serve are minorities, and most of them don't know about the Tuskegee study. That's not something that's part of their knowledge base, but they hear the negative messaging from politicians and negative messaging on television and radio and believe non-credible sources, unlike you all. For back to vaccines for children quickly, what is the opt-in process for providers? It's mentioned because many clinical providers, pediatric offices may not know that they can access vaccines for children or may be concerned about the regulatory requirements when you are a part of vaccines for children. How can we improve that messaging to pediatric practices?
So I think two things. One is the opt-in process. The state is very supportive. We have a wonderful vaccine for children program in Kentucky, and the staff are amazing. But the practicalities are you have to keep 2 vaccine supplies. You have to, for purchase vaccine and VFC vaccine, there's data reporting, ordering. It's just for somebody that has a purchase stock and a vaccine for children stock, it's double the work basically. Vaccines are very expensive. I don't know if people know that, but just to have a set of vaccine as an infant is, $600, $700, $800 just for those vaccines for one visit. So there's a lot of financial risk if your refrigerator goes down, things like that. But so the bottom line is VFC in Kentucky, very supportive staff. You would just reach out to them if you want to participate. I think one of the things is for practices that have very low Medicaid volumes of patients, that they decide that it's just an administrative burden that's too expensive for their offices to bring that on and the staff time and resources that it takes. And so I know the VFC program works carefully to identify barriers, but having them continue to talk to the practices that have either stopped doing VFC or see Medicaid kids with Medicaid and don't do VFC, why not? Like what are the barriers? Because each practice is going to be different. For us, we are mostly, most of our families have Medicaid or are uninsured. So it's rare that I use a purchase vaccine. We use almost 100% vaccine for children. And even for us, there are definitely administrative burdens, data reporting, things like that are hard, but worth it for us because it's such a great program for us. But there's definitely a degree of uncompensated care with that work. We don't receive payment for the number of hours that it takes our staff to administer the program.
Okay. Thank you very much, Dr. Richardson. Dr. Bryant, when you were talking about students, I wrote 2 questions that I don't remember which slide it applied to, but you said that messaging revaccination, that low-income patients, Blacks and Native Americans have lower rates of immunization, not just for COVID, but for all kinds of vaccinations. When vaccines for children is readily available for those populations often, what do you feel is the problem why that vaccination rate is so low?
Yeah, it's a great question. And I think Dr. Richardson really got at the heart of it in her remarks. I think some of it's access. right? And being able to take off work potentially and have transportation to the pediatrician's office. I think we need to consider access first, but that's not the only issue, I'm sure. I suspect Dr. Richardson probably has some additional ideas, given that she's on the front line giving immunizations.
Okay, thank you very much. Dr. Richardson, did you have a comment about that?
So I think that, it's interesting how we have, so immunizations are a public health intervention, and we've linked it to a primary care intervention, right? So we're linking it to a primary care intervention because we think that's the best way to go. Where I was in practice before, it was linked to WIC. Okay. Another intervention. The county's immunization rates were almost 97%. So I just think we have to think about immunizations in primary care are important, but why is that the only place that people can access their immunizations? Like it's some sort of a bond that we're refusing to break. But with COVID, we link it to their community pharmacy, right? That was a huge rollout for the COVID vaccine that we don't typically think about for childhood immunizations globally. So I think if we want to increase immunization rates, we have to think about what we're linking it to and link it to other things, right? We linked it to primary care. We thought that was a great idea, right? While they're there for their checkup, they get their shots. Well, there's nothing sacred about that link. It doesn't have to occur then. And so I just think we need to really think about how we're delivering childhood immunizations and just rethink the whole thing. When we have vaccination rates this low, we have to really broaden and think about it more globally and make it family-centered instead of physician-centered.
Thank you very much. As a seasoned individual, I remember lining up to get my polio sugar cube. And sometimes we got shots in lines in the cafeteria or in the gym in our elementary schools in Washington, D.C. So possible answer would be to link vaccination to the school system rather than where the kids are going to have to be anyway.
Link it everywhere,
yes.
Right? Link it at the grocery, link it wherever people are, because if we want to increase vaccine rates.
Okay. Dr. Castrucci, you've mentioned that we have to go from concern to confidence. When I surveyed my staff, 48% of healthcare staff refused the COVID vaccine because they had concerns and they weren't confident about the vaccine despite all the messaging and being in the healthcare industry. What can we do so that laypersons who are not in the healthcare industry also can go from concern to confidence?
This pandemic is always going to be, hopefully, it is always going to be unique. And I would argue that early on in the pandemic, we were given some framing that has always made it very difficult for us to really get the vaccination rates that we wanted. We had elected leaders saying, it's not that bad, wouldn't trust this vaccine. And those things came back to haunt us later. And I've watched a lot of politicians try to put that back in the box. And sometimes those things you let out of Pandora's box aren't so easy to push back in. What we need to do is we need to mobilize trusted people in the community. We need to get the moms, the dads, the pharmacists, the physicians, the faith leaders to stand up and say, I've taken it. This is why I've taken it. Many of the people who spoke out against vaccination were vaccinated. There are a lot of hard conversations that we're going to have in this country after the pandemic is over.
And we did not get, thank you so much. We did not get to all of our questions in the chat, but I'll ask if there's a way to answer these without it. We have to wrap up now because we're at the 12 stopping point.
Yes, Anne, we definitely will capture the questions that were not answered, and we'll do our best to get responses back to the audience members who asked them. Thank you so much to Ann Hagan-Grigsby and our panelists today for this panel. I learned a lot that I didn't know about the Vaccines for Children program and about people's opinions. And I was interested in the thoughts that you shared about how we can move into a real health discussion with our healthcare professionals and away from the politics.